Very good morning, one and all. Presenting a seminar on the topic of functional analysis, construction by. The contents of the seminar will be as follows. It will be divided into two parts: functional analysis, and the second part will be the taking construction by. Functional analysis will be covered under the following headings: postural rest position of the mandible, path of closure of the mandible, examination of the TMJ, examination of the orofacial functions. Second part will be covered under the following headings: the construction by twin block, for activator appliance, for bionator, for Frankel appliance, post appliance delivery instructions, followed by conclusion and references. Functional examination is the very important and first crucial step in the examination of the patient when the patient arrives in the dental clinic, because the etiologic evaluation of the abnormality and determination of diagnosis and treatment planning, functional examination is essential. Examination of the stomatogenetic system is very important because any of the component, if follows the dysfunction, it does not stay apart. Rather than it affects the whole stomatogenetic system. It includes the masticatory function, deglutition, examination of speech function, respiration, and the posture of the components. So why do we need to do functional analysis? Because normal functioning of the orofacial complex and important plays an important role in optimal growth and development of the face. Dysfunction of any of the component can lead to malocclusion, development of malocclusion, and so knowing and treating the exact etiology of malocclusion is the ultimate goal of doing the functional examination in the dynamic treatment. Functional examination has three parts like examination of the postural position of the mandible and the interocclusal clearance, examination of the temporomandibular joint function or dysfunction and condylar movement, examination of orofacial dysfunction. First, let's begin with the assessment of the postural position of the mandible. To examine the mandibular position as determined the musculature is known as the postural position of the mandible. Rest position of the mandible is influenced by the body, head, and posture, and resting position is the position of the mandible in which the synergistic and antagonistic musculature components are in dynamic equilibrium and all muscles are in minimal contraction stage, and it is the most comfortable stage for the patient. So when patient moves mandible from resting to habitual occlusion, so there are two parts: resting point to the initial contact of the teeth that follows the free phase and the hinge movement of the condyle, and second part from initial contact of the teeth to the centric occlusion that has the articular phase and also called as the sliding movement of the condyle. So the functional pattern of the mandible, the movement of the mandible with sliding up to 2 mm, it is normal, and sliding is more than 2 mm, that is considered abnormal. The etiology in that case might be the neuromuscular abnormality, might be the disturbance in the upper and lower teeth interrelationship or jaw relationship. There must be some premature occlusion, and the compensation of a skeletal discrepancy can be one of the reasons. Here we can see the initial movement in the early phase and the late phase of the mandible. During the opening of the mandible, when patient opens the mandible during the early phase, there is pure rotation movement in the fossa that follows by the late phase, which has the pure translatory motion in the fossa of the condyle. The condyle moves during the initial phase. The upper jaw part of the jaw, half of the jaw, upper half of the joint has the pure rotatory motion, while in the later phase it has the pure translatory motion. Rather than while patient closes from the rest position to the occlusion, it totally reverse. First it is the rotatory motion, then follows by the sliding movement. We can consider like if this is the fossa of the joint of the TMJ, and this is the condyle. So when patient moves from the resting position to the occlusion, the condyle first rotates in sagittal direction, then it goes backward sliding. This is the case from resting position to the occlusion. When the patient opens, it is first rotatory motion, then the mandibular condyle slides in the joint. So what is postural rest position? How to record it? Patient should be sitting in the upright position. Back of the patient should be unsupported. Frankfurt horizontal plane of the patient should be parallel to the ground, and patient looking straight ahead at eye level, and patient should be relaxed while recording the postural rest position. There are different methods recording of postural raised position of the mandible, like phonetic method, giving the command method, non-command method, and the combined method. Coming to the first is the phonetic method, where we can we request the patient to repeat the selected consonants, like the letters that starts M or C, like Mississippi and all, can be used based on the fact that the mandible returns to its normal postural raised position. Or else we can request the patient to lick his or her lip, then swallow to allow the mandible to return to its postural raised position. Next method is the combined method. This method is the most suitable method for functional analysis in the children. We do not ask the patient, we keep talking with the patient, and patient does not have any idea that what he is being examined for. So if patient is first observed during swallowing and speaking, and in older children, we can use the tapping test, that is the test to relax the musculature in the patient. It is carried out in order to relax the musculature. So what is the tapping test? Tapping test is that we hold the chin in between the thumb and the forefinger, and clinician guided the mandible and do the passive movement of the mandible so that the musculature can be relaxed prior to determining the raised position. So this registration of postural raised position can be done by three methods: direct intraoral methods, direct extraoral methods, and indirect extraoral procedures. So in direct intraoral procedures, we can use the Vernier caliper that can be directly measured in the patient's mouth, in the canine or incisor region, to measure the freeway space. We measure the distance between the two gingival margins. In direct extraoral procedure, two marks are placed on the patient, one on the tip of the nose and second at the tip of the chin, and the distance between the 2 points is measured after instructing the patient to remain at rest position. Later, the patient is asked to occlude the teeth, and the distance between the 2 points is again measured. The difference between the two readings is the freeway space. And the next procedure is the indirect extraoral procedure. The indirect interocclusal space is determined by using a radiograph. Lateral cephalograms, 2 lateral cephalograms can be taken at rest position or other in the centric occlusion position that can help to determine the freeway space. Coming to the evaluation of the relationship of the mandible in postural rest position to the habitual occlusion. Whenever the patient moves the mandible from postural rest to initial contact, just before the centric occlusion, from postural rest to initial contact, the condyle follows the pure hinge movement, and the movement from the postural rest to the initial contact records the pure hinge movement of the condyle. And when further patient moves the mandible from initial contact to habitual occlusion, that gives the translatory motion of the condyle in the sagittal plane. So the cephalometric method is considered to be the most reliable in providing successful results. We can obtain 3 lateral cephalograms, first in the postural rest position, second in the initial contact of the teeth, third in the habitual occlusion, and movement from the postural rest to initial contact records the hinge movement of the condyle. The path of closure, the closure of the mandible from postural rest to centric occlusion is also called as path of closure. And path of closure can be examined in 3 planes, like sagittal plane, vertical plane, as well as in the transverse plane, because there are different path of closures in different malocclusion. That is why it's very important to determine, so that we can judge during the diagnosis and treatment planning how much mandible should be advanced, either in sagittal plane, transverse plane, and in the vertical plane. The movement of the mandible from the rest to occlusion can be pure hinge movement, it can be partly hinged with anterior sliding, and it can be partly hinge movement with posterior sliding component. Let's see one by one. Assessment in the sagittal plane for class 2 malocclusion. In cases where skeletal true class 2 cases, straight upward and forward path of closure will be seen. Straight upward and forward path of closure will be seen. That is called as forward shift, and that brings the pure hinge movement in the condyle and appears less severe than actually they are. And these cases are true class 2 cases, while in the cases those are including the functional class 2 are called functional class 2 cases, where upward and backward movement path of closure of the mandible will be seen. That is called as posterior shift, and there will be a combination of the rotatory as well as sliding movement of the condyle will be seen, and it appears more severe than actually it is, since the mandible is closing in the more posterior direction upward and backward. So the class 2 skeletal discrepancy, when we look at the patient in the sagittal direction, it appears more severe rather than actually it is. So it is called as functional class 2 case. So true class 2 has the upward and forward, though the skeletal discrepancy little bit is masked due to the path of closure of the mandible. Mandible is coming forward, upward and forward. The actual discrepancy, skeletal discrepancy is masked little bit. Though in the functional class 2 cases, the actual skeletal discrepancy looks more severe due to the backward path of closure of the mandible. Same assessment in the sagittal plane in class 3 malocclusion. There will be true class 3 case, different path of closure for severe class 3 and functional class 3. Let's see one by one. In true class 3, there will be path of closure will be straight path of closure. Mandible just come and touch the maxilla and closes in the synaptic occlusion. Straight path of closure, there will be hinge movement of the condyle, as well as this is seen in the true class 3 cases. In severe class 3 cases, upward and backward, there is some muscular and skeletal decompensation already has occurred. In those cases, severe class 3 upward and backward path of closure will be seen, and posterior shift in class 3 will be seen. That brings the combination, the rotatory as well as sliding movement of the condyle, and it appears less severe than they actually are. Skeletal discrepancy is much more what appears during the examination because of the backward path of closure in class 3 cases. So these cases, these path of closure can be seen in the severe class 3 cases. Coming to the functional class 3, in functional class 3, upward and forward movement path of closure of the mandible will be seen, and there is an anterior shift of the mandible in class 3. Combination of the rotatory as well as translatory movement in the condyle will be seen, and it appears more severe since the path of closure is forward and upward in class 3 cases. So skeletal discrepancy appears more severe than actually it is. So these path of closure seen in the pseudo class 3 cases. Coming to the assessment in the vertical plane, it is important for the prediction of therapeutic efficiency of the myofunctional appliances, or before going to functional therapy, very important to analyze, to examine the vertical path of closure in the vertical dimension or vertical plane. Amount of occlusal clearance is the distinguishing feature between the true deep bite and the pseudo deep bite. In the true deep bite, overbite has the large interocclusal clearance during the rest position. It has the large interocclusal clearance during the mandibular rest position, and there will be infraocclusion of the posterior segments of the mandible or the posterior teeth. So it has the good prognosis for functional appliances. And in pseudo deep bite cases, where the pseudo deep bite overbite problems, small or normal interocclusal clearance will be seen. These cases are usually due to the over eruption of the incisors or the anterior teeth. There will be normal eruption of the posterior teeth, and these cases have the poor prognosis with functional appliances. These cases are usually due to the over eruption of incisors causing deep bite. So let's see the growth pattern and prognosis. Type of deep overbite. If there is true deep bite, in vertical growth pattern has the good prognosis. True deep bite having the increased interocclusal distance, interocclusal clearance. In horizontal pattern also has the good or moderate prognosis. Pseudo deep bite having the vertical growth pattern have the limited prognosis, and the pseudo deep bite having the horizontal growth pattern having the very limited success in the functional appliance therapy. Coming to assessment of the path of closure in transverse plane. So the observing the position of the mandible midline as the mandible moves from postural rest to the occlusion is very important, and distinguishing feature between skeletal and dental crossbite, or we can say the skeletal and dental true crossbite in the transverse plane. So indications and contraindication we should know for them, and prognosis of the functional appliance is also very important. We should go for the examination in transverse plane. In cases of pseudo crossbite, the midline shift in occlusal position is seen, while in the occlusal rest position, midline is coinciding and well centered. Since the jaws are well centered and well coordinated, so this case might be due to the tooth guidance or the occlusal prematurity is causing the pseudo crossbite. And the true crossbite in cases where the crossbite asymmetrical facial skeletal is present, and the midline deviation seen will be both in the habitual occlusion, in the centric occlusion, as well as in the resting position. That gives the clear-cut indication of the skeletal discrepancy. In transverse plane, the laterognathism, the skeletal jaws discrepancy, midline in rest position will be shifted, midline in the occlusion will also be shifted, and prognosis will be poor. Though in the lateral occlusion, that means the crossbite due to the dental patterns in midline In the rest position will be well centered and midline in occlusion is shifted. That gives clear indication that it is due to the dental premature occlusion or something that is causing the jaws, or that is causing the mandible, that preventing the mandible to occlude in the centric occlusion. Next part is the examination of the TMJ. Temporomandibular joint is very important, and different methods for examination are the auscultation, palpation, and the functional analysis. Before going to examination of the TMJ, we should have watched at this video to understand the movement of the mandible in the mandible and condyle in the fossa, as well as the articular disc.
The disc is biconcave and it's located in the superior position. The central thin part of the disc is consistently lying in between the
You can see how the patient moves mandible, opens the mandible, condyle moves downward, rotate, then sliding motion. While reversing back, first is the rotation. Examination of temporomandibular joints and associated structures to assess the normal or abnormal joint function, clicking, pain and dysfunctions are characteristic features of pathologic temporomandibular joints. We should look for any clicking noises, possible source of the muscles, mandibular deviation on opening and closing, signs of any parafunctional habits, and overall stress level of the patient. First method is auscultation. By keeping the stethoscope on the condyle or condylar joint of the temporomandibular joint or that area, and asking the patient to perform, telling the patient to open and close the jaw into full occlusion. Check for the signs of clicking or crepitus. This is the first method. Second method is the palpation. Right and left condyles to check for the synchrony of the action. We should also check for the tenderness. Lateral palpation of the TMJ can be done by using the slight pressure on the condylar process with the index finger, and the posterior palpation of the TMJ can also be done positioning the little finger in the external auditory meatus and palpate the posterior surface of the condyle during opening and closing jaw movements. It's very important. So differential diagnosis of the joint should be made, whether it is the discrepancy or pain or any complaint of the patient to the TMJ. It is due to the internal derangement, or it is due to the muscle myopathy or myofascial pain, or it is the combination of the two. We should make the differential diagnosis for this. Joint noises like clicking and crepitus are seen due to the anteroposterior or eccentric movements of the mandible that can be detected using stethoscope or digital palpation. So the clicking of the temporomandibular joint is differentiated as the initial clicking, intermediate clicking, terminal and reciprocal clicking. It's very important to understand. Initial clicking, how it happens? Initial clicking happens when the disc of the joint comes displaced anteriorly to the condyle. Then while opening the mandible or opening the jaw, the clicking sound appears. Let's see this video where the anterior displacement of the disc, how it happens.
In this joint, the disc is anteriorly displaced, and it's reduced on opening when you click.
See how the clicking sound appears.
This joint demonstrates reciprocal
The chuck movement appears
between
the condyle and articular disc.
closing.
See, this movement happens. This produces the clicking sound.
The disc is here again anteriorly displaced. The configuration of the joint compartments corresponds very well to what has been seen on arthrograms and to observations during surgery.
So this is the initial clicking. Initial clicking is due to the anterior displacement of the disc in relation to the condyle. While opening the mandible, there is chuck movement between the condyle and the articular disc that gives the clicking sound. Intermediate clicking is observed in patients with uneven condylar and articular surfaces. And terminal clicking is a sign of condyle being moved too far anteriorly, if the patient opens too much over the limit, that causes the displacement of the condyle in anterior displacement of the condyle in relation to the disc, that causes the terminal clicking. Reciprocal clicking is observed during opening and closing and is suggestive of incoordination between displacement of the condyle and disc. It happens during the both movement while opening as well as during the closing, that gives the reciprocal clicking. Coming to the next, that is crepitus joint sound. It observed as a cracking sound comes from the joint. It indicates a rough condyle as well as disc or the eminent surfaces. Occurs as a result of direct and long-term bone contacts between the fossa and the condyle. So here we can understand it that the staging of the internal derangement of the TMJ, this is the optimal disc position. This is the first stage where the clicking and popping starts, and second is that this reduced to its back to its normal position. But when this phenomena continues and the disc this remains anterior to the condyle, the condylar surface, bony surface, comes in contact with the bony surface of the temporal bone, and that gives the crepitus sound. Due to the roughness or long duration of the bony contact between the two surfaces, gives the crepitus sound. So let's compare the normal TMJ movement along with the clicking sound, clicking movement. We can compare, distinguish the difference between the movements. Most of the cases, patient comes due to the comes with the clicking sound or the pain of the TMJ. In those cases, most of the cases have the anterior displacement of the disc. This posterior disc, retrodiscal guide, has the very high vascular and nervous tissues that causes the severe pain to the patient. That is why these situations are unbearable for the patients. So the opening and closing movements of the mandible should also be evaluated. Deviation or the extent of these movements, opening and closing, the mandible usually tends to deviate towards the side of anteriorly dislocated disc. Mandible tends to deviate towards the side of anteriorly dislocated disc. Since the condyle goes posterior to the disc, so this side mandible shifted. So uncoordinated zigzag movements of the mandible is due to the asynchronic contraction of the muscles, and normally there should be 35 to 45 mm of mouth opening in the normal individual. There are two situations called closed lock and open lock. What happens? Patient is in closed lock, patient is unable to open the mouth due to the anteriorly displaced disc interfering with opening movements. And in the open lock, patient is unable to close the jaw due to the posteriorly displaced disc may not allow the condyle to come its original position in the fossa. If the joints demonstrate excessive mobility or hypermobility, it should be recorded in order to avoid overstretching of the muscles that already have compromised ligaments. Next part of functional examination is the examination of the muscles. Musculature should also be examined for possible pain or sore in the neck and mouth area, so that we can differentiate between the skeletal component of the pain and the soft tissue component of the pain. Palpation of the muscles during mandibular movements is the very significant part for diagnosis and treatment planning. The lateral pterygoid and masseter muscles should also be palpated in every orthodontic patient. So the palpation of the lateral pterygoid muscle, we should insert index finger and we should palpate with the pulp of the index finger in the posterior in the region posterior to the second maxillary molar against to the maxillary tuberosity. And for the palpation of lateral pterygoid muscle, we should keep index and middle finger on the region of the temporal area above the external auditory meatus and ask the patient to do the mandibular movements. For the palpation of masseter muscle, we should hold two fingers, the pulp of the two fingers at the anterior border of the masseter muscles and ask the patient to do the movements. Simultaneously, we can palpate the other region of the masseteric area. For the palpation of the medial pterygoid muscle, we insert the index finger on the inner part or inner side of the ramus and ask the patient to do the mandibular movements. We can check there for the tenderness. All four masticatory muscles, important muscles, should be checked for the tenderness. Also, during a functional examination, we should look for the parafunctional habits because nighttime clenching caused due to the stress or any other reason in many individuals result in the morning headaches. That is very important symptoms. Occlusion should be analyzed during various border movements, lateral, protrusive, excursive movements of the mandible for any prematurities of the occlusion or the deflective context causing the stress of or stretch of the muscle. At the end of orthodontic treatment, the patient should be left with a healthy masticating musculature and good functional occlusion in centric, lateral, excursive, and protrusive movement. That is why we should check before doing the orthodontic treatment. Coming to the next part, that is examination of the orofacial function, difference function. First is the examination of the tongue posture, tongue size, tongue function, and tongue dysfunction should also be checked. For the tongue function, abnormal tongue function like tongue thrust plays important role in key pathogenesis of malocclusion. Primarily, it is due to the retained infantile swallow or pressure habit or any abnormal habit. Secondary tongue thrust due to the skeletal discrepancy like class 2 D1 cases, or the anterior region if there is tongue thrust is found that causes the anterior open bite. If the tongue thrust is lateral, causes lateral open bite, and it can be complex tongue thrust causing the contact only in the molar region. Rest all region have the anterior open, have the open bite. Tongue posture should also be examined physically with the mandible in postural disposition. Normally, the tongue touches the palate of the individual, and posture and the shape can be narrow and long, protracted or retracted, displayed laterally and shortened, flat or arched can be possible. Normally, if there is abnormal tongue posture, the tongue lies in the floor of the mouth, causing the abnormal development of the face or the maxilla. Next function is the swallow. In newborn, tongue is large and is forward sucking postural position. Tip of the tongue inserts through anterior gum pads for anterior lip seal while suckling. This is termed as infantile swallow. Later, with eruption of the incisors, tongue position starts to retract. With normal development, postural, functional, and proprioceptive changes causes mature swallow. Functionally balanced or mature somatic swallow occurs without contracting the muscles of facial expression. The tongue inside the mouth and the teeth momentarily are in contact. Abnormal swallow is caused by retained infantile swallow or tongue thrust. Infantile swallow is gradually replaced by somatic or mature swallow as proprioceptive impulses causes tongue postural and functional changes. Under normal developmental pattern, the functionally balanced or mature swallow is established between 2 to 4 years of age. Infantile swallow, also called as visceral swallow, tongue posture is forward and depressed with furrow in the mandible, and perioral musculature, contraction of mentalis, orbicularis oris, and facial muscles are seen in the infantile swallow. While in the mature swallow, it is called adult swallow or somatic swallow. Normal and upward position of posture of the tongue against the palate. No contraction of the facial muscle seen in the mature swallow, and tooth contact. Yes, teeth are in contact during the mature swallow. Here we can appreciate the normal swallow. The position of the tongue, lip musculature are relaxed and teeth are in contact. While the infantile swallow, gums are apart, tongue is positioned in between the lips, causing the suckling, facilitating the suckling movement. Next function is the respiration. Examination of the respiration also plays very important role in diagnosis and treatment planning because to determine the mode of breathing, impaired breathing causes impaired function of the orofacial musculature that interferes with the normal development of dentition as well as with the orthodontic treatment. Oronasal breathing typically present with constricted upper arch, deep palate, crossbite, poor oral hygiene and gingival hyperplasia, and tongue posture and function is also disturbed secondarily due to the skeletal discrepancy. Respiration, abnormal respiration pattern. If it is habitual mouth breathing without respiratory resistance, functional therapy is indicated. Abnormal respiratory patterns is structural problems with excessive adenoids or allergies. It is advisable to seek an ENT consultation and possible treatment. And structural conditions cannot be altered. Functional appliance therapy is not indicated. Active fixed mechanotherapy and stability of result is questionable. Examination of the speech and malocclusion. Abnormalities of teeth and jaws usually interferes with the speech normal production of the certain sounds. Impaired speech may require orthodontic treatment to correct abnormalities of teeth and jaws contributing to speech pathology. First, the orthodontic or orthopedic treatment should be done to correct the skeletal discrepancy of the jaws as well as the face. After that, it should be followed by effective speech therapy. Before speech therapy, we should go for correction of orthodontic and orthopedic discrepancies. Next part is the examination of the lips. The lips are competent or incompetent, but can be potentially incompetent. Competent lips have the slight contact or very small gap between upper and lower lips. Incompetent lips have the wide gap between two lips or shorter upper lip. Potentially incompetent lips have normally developed lips, but upper incisors are labially tipped, making the closure of the lips very difficult. Next part of the seminar is the construction bite. Sagittal advancement taking the construction bite. First is the twin block appliance. For taking the construction bite, the George bite gauge is used, which has the millimeter gauge to measure the amount of advancement in the protrusive path of the mandible to determine the accuracy amount of activation registered in the construction bite. Exacto bite of the project bite gauge also be used. It is designed to record a protrusive bite for construction of the twin block. The blue black bite gauge has registered 2 mm vertical clearance between the incisor. That is, most of the time it is useful in the cases of class 2 division cases. It registers 2 mm vertical clearance between the incisal edges of the upper and lower incisors. It is equivalent to approximately 5 or 6 mm clearance in the first premolar region. It gives the different notches. We can see the upper part of the exacto bite has the different notches for the maxillary anterior teeth, and the lower part has the single one notch. By utilizing those notches, we can approximate the relation of the maxilla and the mandible. The total protrusive moment is nothing but the overjet in the centric occlusion minus the maximum protrusion of the patient. The functional activation within normal physiological limit should not exceed 70% of the protrusive path. Beyond this range, the muscle and ligaments cannot adapt to the altered function, and the patient will tend to posture out of the occlusion. Patient will not keep the appliance in the occlusion. Patient will keep the appliance out of the occlusion. So there should be 70% of the maximum protrusive path to limit the activation in the physiological limit. Because once we proceed more than the 70% of the maximum protrusive path, the medial collateral ligaments causes the backward pushing of the disc and causing the unseating of the mandible, giving the tenderness to the TM joint, giving the discomfort to the patient, and patient causes the disocclusion of the appliances. So activation of in the construction bite, whether to go for one step or two step. Usually activation in the construction bite is aimed for single step advancement, but if the overjet is more than the 10 mm, 2 mm advancement can be done. Patient who have the vertical growth pattern, they have very weak musculature, and we are unable to maintain the forward mandibular posture consistently. Therefore, in those cases, it is advisable to go for the 2-step advancement. For the vertical activation, the amount of vertical activation is crucial to the success of twin block therapy. Block should be thick enough to open the bite slightly beyond the freeway space to ensure that the patient should not occlude out of the appliance in the mandibular rest position. That is why we should go 2 to 3 mm beyond the freeway space. A judgment should be made while recording made according to the amount of vertical space between the cusp tips during the postural rest position of the mandible, that is counted between the first premolars and deciduous molar, to achieve a correct degree of bite opening to accommodate blocks of at least 5 mm thickness. Next appliance is the Frankel appliance. Taking the construction bite. The procedure of taking the construction bite is done by retooting the mandible. First, we take the mandible in the centric occlusion, and then the vertical opening is kept to a minimum to allow lip closure with minimal stress. The purpose of this mandibular manipulation in any of the construction bite is to relocate the jaw in the direction of treatment object 2, the direction where you want to grow the mandible. This creates artificial functional forces and modifies the function to encourage the normal development of the skeletal component. Function we create by giving the appliance, we create artificial forces that modifies the form of the skeleton. Usually the advancement in the functional Frankel is 2.5 to 3 mm. Vertical opening should be only large enough to allow crossover wires to pass through between the interocclusal space without contacting the teeth. Anteriorly, it should not be more than end-to-end or edge-to-edge bite. Next appliance is the activator, where the construction bite proper activator fabrication requires the determination and reproduction of the correct construction bite or working bite. The purpose to relocate the jaw in the direction of the treatment objectives, and this also creates artificial functional forces that forces alters the form. Before taking the construction bite, the clinician must prepare by making a detailed study of the plaster cast, cephalometric and postural head films, and the patient's functional analysis in all of the cases of the appliances. So there are three different streams of thought exist here: minimal vertical opening, extreme vertical opening, moderate vertical opening in activator appliance. But the Graeber and Newman said use a combination of bite opening and protrusion equal to trim. This is not a rule. This is just an approximation is given for understanding. In other words, if you open the bite 4 mm between the occlusion posteriorly, the advancement of the mandible should be 6 mm. But according to Clark in twin block cases, the minimum opening, vertical opening should be 5 mm. Bite for bionator, the procedure to record the construction bite for bionator is same as that of use for the activator. But along with the objective to achieve class 1 relation of arches, there is one more objective in the bionator of during taking construction bite, and that is the edge to edge relationship of the incisors. Why is to edge relationship of the incisors is important? Because this will provide maximum functional space for the tongue, since we are bionator works on the principle of force modulation, and convenient for the patient also to maintain the mandible in this edge to edge position. There can be possibilities like maxillary center incisors are proclaimed. In those cases, edge to edge relationship of at least lateral incisor can be made, and if budget is too large, stepwise advancement of the mandible should be done. In vertical plane, in activator vertical bite opening, it is desirable for allowance of growth to occur, whichever dimension of the growth we want. Activator vertical bite opening is advisable, desirable, while in the bionator, vertical bite opening is not desirable, edge-to-edge bite recording is advisable. So according to Walter, if vertical bite opening is more for bionator, that can lead to tongue thrust habits. That is why in the bionator construction bite, we should keep edge-to-edge bite. So in making the construction bite, general rules to follow are: in case the budget is too large, the forward positioning is done stepwise in 2 or 3 phases. In case of forward positioning of the mandible by 7 to 8 mm, the vertical opening should be slight to moderate, 2 to 4 mm, just 2 or 3 mm beyond the freeway space. If the forward positioning is not more than 3-5 mm, the vertical opening can be increased to 4 to 6 mm. In taking construction bite, one should look at the bite in 3 different planes: sagittal, vertical, or frontal plane. Sagittal plane, the anterior posterior position of the mandible should not exceed 7 to 8 mm or the 3/4 of the mesiodistal dimension of the first permanent molar. The class 2 cases, anterior positioning to this magnitude is contraindicated when the budget is too large. There is severe labial tipping of the maxillary incisors when the incisors are upper incisors are lingual erupted. In the vertical plane, we should assess the construction bite. Mandible must be dislocated in at least one direction from postural rest position, either in sagittal direction or in the vertical direction. Mandible should be dislocated from its postural rest position to activate the muscles. This is essential to activate the muscle and induce a strain in the tissues. If magnitude of forward positioning is greater than 7 to 8 mm, the vertical opening should be minimal so that the muscles are not overstretched. If extensive vertical opening is required, the mandible must not be positioned anteriorly. In the transverse plane, the patient is observed in postural rest position to check the midlines, and it is then asked to slowly close the mandible, keeping the bite wax inside the mouth. Ask the patient to slowly close the mouth into the full habitual occlusion. If the midline of postural rest position and occlusion is coinciding, there should be no change in the construction bite, while postural rest position coincides with the midline, while occlusal position does not coincide with the midline. This is due to the shift from one side to other, and occlusal interferences or prematurity should be checked in the bite. If the upper and lower midlines do not coincide, a determination must be made so as to fall whether it is due to the maxillary or mandibular prematurities. Coming to the last part is the post appliance delivery instruction in case of twin block patient. Like, patient should be demonstrated about insertion and removal of the appliance. Patient should be asked to wear the appliance on the first day 24 hours, and then immediately next day we should take the next visit, so that we should check for any ulceration or anything that is any hurt that is causing to the patient. And next visit should be on the next day. Patient should gradually increase the wearing time. Eating with the appliance in place is essential to generate the impulses to direct the skeletal system toward the treatment objective. If the patient removes the appliance during the eating or chewing, the whole impulses that is going to the skeletal system is the link is broken if the patient removes the appliance. That is why it is advisable, it is essential that the patient should wear the appliance while eating. Patient should wear the appliance maximum time, but for school-going children, night time wear is also sufficient. A patient should ask to clean the appliance with Cleansodent tablet once a week to maintain the hygienic and clean appliance. So I would like to conclude by saying that the functional examination is crucial in diagnosis and treatment planning. So careful examination of the patient should be carried out before proceeding to functional appliance therapy, because dysfunction of one component does not remain separate, but it affects the whole stomatogenetic system. Patient compliance is an essential part of functional therapy. Activation and construction bite should be moderate enough to balance between muscle activation and patient comfort in order to gain maximum efficiency of the therapy. These are the references.